The first attack came in the form of an acrylic mucosa-borne denture. The damage caused was extensive. The second attack was possibly even worse. The cobalt chromium denture covered too many gingival margins. It lacked effective support. The patient was not prepared correctly and was probably not aware of the scale of the damage. They are both examples of a partial denture nightmare, but the damage is avoidable.
We all know that partial dentures are capable of damaging the oral tissues. In fact, one patient has described a partial denture as a device for losing one's teeth slowly, painfully, and expensively. But there is strong evidence that dentures can maintain and even improve the health of the mouth. This is a program about the principles which govern good design of removable partial dentures and their long-term success. A favorable outcome involves an alliance of the practice team, whose job it is to diagnose, motivate, design, treat, and provide ongoing care, the dental technician, who's responsible for the precise construction of the denture, and of course, the patient, who must control plaque and follow the aftercare advice of dentist or hygienist. There are several reasons for the failure of partial dentures: plaque, bad design, bad construction, poor maintenance. Let's take a closer look at the first, plaque.
Over the past 15 years, a great deal of evidence has been gathered which shows that denture wearing encourages plaque formation. Several studies in particular leave no doubt about the problem. For example, the experiments by Addy and Bates into plaque accumulation at the Welsh National School of Medicine and the earlier studies undertaken in 1976 at the Royal Dental College in Copenhagen.
Details of these studies can be found in the booklet that comes with this program. But if anyone doubts that dentures can't be worn without damage, consider the work of Professor Bergman and his colleagues in Sweden.
Professor Bergman's team reported that there was no significant difference in the mean plaque index between a denture-wearing group and a control group during several years' monitoring. They proved that successful denture wearing was inextricably linked with effective plaque control and, crucially, good design.
There was no magic involved in the Bergman results, just regular oral hygiene instruction and sound design principles. Keep gingival coverage to a minimum, keep the design simple, make sure there's adequate tooth support. Spread the forces as evenly as possible by using rigid connectors. Simple, basic principles, but all too often ignored, as in this first example.
This lingual plate covers, of course, all the gingival margins, and the lack of positive tooth support increases the risk of resorption of the bone in the saddle areas, as well as damage to the periodontal tissues, especially of the abutment teeth. Now let's look at a better design for the same arch and check it against the 4 basic principles. The gingival margins are now uncovered, and positive tooth support has been included. The denture is not cluttered with unnecessary components, and the rigid sublingual bar ensures a wide distribution of functional forces. And let's not forget acrylic dentures. They may be low cost, but they don't have to be badly designed, like this example, which replaces 4 teeth but covers the gum margins of 9. Talk about risky. Here's a healthier alternative, where specific instructions have been given to the laboratory to free the gingival margins.
Which brings up the whole topic of responsibility for design and quality of prescriptions.
Good morning.
There's really no question about responsibility. The dentist's is to prescribe the best denture design for the patient. The technician's is to interpret that prescription. But the only way that's going to work is for the two to communicate with each other.
And then I put it down on your lap slip, and I think...
Studies have shown that the quality of prescriptions has improved over the last 10 years, and the number of dentures being made without any prescription has halved. A gratifying improvement. But it's still disappointing to find that the dental technician has to take the design initiative for the vast majority of cobalt chromium dentures. So let's look at how the Alliance can and should go about prescription, design, communication, construction, fitting, and aftercare.
And how have you been, Mr. Wood, since I last saw you?
Very well, thank you.
The first step is to gain an accurate picture of the patient's dental and medical history, including their motivation. This is an essential part of planning any treatment.
Right, first of all, let's just do a little examination of your muscles.
As is a thorough examination, which should begin with an extraoral assessment.
And clench. That's excellent. Now, if you'd just like to slip your dentures out for me, please.
Followed by an intraoral to establish the level of hygiene, quality of existing restorations, and the state of the soft tissues. And at this stage, impressions for a study cast should be taken. Study casts are the foundation of good denture design, and when these are returned from the lab, the clinician needs to survey them to gather the best possible information on which to base the design. Surveying instruments such as this cost around £150. The surveying procedure is quite straightforward and is carried out in two distinct stages. The first survey is undertaken with the occlusal plane horizontal. This is in order to identify undercut areas, which could provide retention in relation to the most likely path of displacement of the denture, at right angles to the occlusal plane. Once these areas have been identified, we need to consider whether there are any advantages to be gained by making the direction of the path of insertion differ from the path of displacement. This can be done for three reasons: to improve appearance, avoid interference, or to increase retention. Let's consider each in turn. Here, if an anterior saddle is inserted at right angles to the occlusal plane, the denture cannot make close contact with the mesial surfaces of the abutment teeth because they are undercut. The result is an unsightly gap between saddle and tooth. However, if the cast is surveyed with the heels down to make the path of insertion parallel to the mesial surfaces of the abutment teeth, the unsightly gap can be closed and the denture made to blend with the adjacent structures, thus creating a much better appearance. Sometimes it's not possible to place a component of a partial denture correctly when using a path of insertion at right angles to the occlusal plane, because a tilted tooth or bulbous ridge, for example, gets in the way. In this instance, the lower premolar is instanding, so that to avoid it during insertion, the connector would have to stand well away from the ridge. Tolerance would be a problem. But as the heels of the cast are tilted upwards to alter the path of insertion, the interference is eliminated, allowing the connector to be positioned close to the lingual surface of the ridge. On occasion, tilting the cast makes it possible to gain retention by placing a rigid part of the denture in intimate contact with the tooth surface that's undercut, relative to the path of displacement, as seen in this saddle, where contact with the distal surface of the premolar is helping to retain the denture. Once it's decided that there are advantages to be gained from an alternative path of insertion, A second survey should be carried out using a different color, with the cast at an appropriate tilt corresponding to the chosen path of insertion. When this is done, the technician must be made aware of the tilt that was used in the second survey. Details of suitable methods are given in the booklet. Before leaving the subject of surveying, its importance and value, even for the simple mucosa-borne acrylic denture, should be mentioned. Here we can see that the acrylic would have been finished in an undercut area. What should be a straightforward process at the fit stage becomes time-consuming, potentially expensive, and frustrating. The acrylic would have to be removed, leading to a lack of adaptation around the teeth. The denture would then be loose, or likely to produce considerable gingival damage. However, if only a few moments care and attention are given to blocking out the unwanted undercuts, the denture can be finished correctly, and this need never happen.
Time to get down to the business of designing, the clinician's business.
We'll start.
Since we couldn't possibly show all permutations in one program, what follows is a clinical example which demonstrates the fundamentals of good design.
Very good.
Further examples can be found in the accompanying booklet.
Right tooth.
This patient required replacement of a well-tolerated but poorly designed cobalt chromium partial denture, which has now become loose and has produced inflammation of the gingival tissues. The final solution included bringing the periodontal tissues back to good health before providing crowns on 4 of the upper teeth made to replace very large amalgam restorations which had become unsatisfactory. Before these crowns were constructed, the design of the denture had been finalized. The correct design sequence or system of design used to arrive at the solution should include consideration of items such as saddles, support, retention, bracing and reciprocation, indirect retention, and connectors. It is applicable to all situations. In the case of our example, a path of insertion was chosen that would allow the use of a flange for optimum appearance. It was decided to use positive tooth support for the anterior saddle, and the retentive clasps were positioned appropriately for the anterior saddle. They are seen to originate distally and to terminate in a mesial undercut. If the anterior saddle is displaced occlusally, the tips of the retentive clasps will also rotate in an occlusal direction, and thus will resist the displacement as they flex against the bulbosity of the tooth. Bracing and reciprocation were obtained by the clasp arms on the palatal surfaces of the first molars. And finally, it was decided to use indirect retention and a rigid connector. The overall design was planned for minimum gingival coverage. There are several ways of making sure the design prescription fulfills the task of getting clear and comprehensive information from the dentist to the technician. But the 2 most important factors are accuracy and clarity. And perhaps in the not-too-distant future, it may be achieved by using advanced computer-aided design techniques. Whatever method or combination of methods are used, they should always be accompanied by an outline of the connector on the master cast, comprehensive written details, and precise specification of materials to be used. Similarly, the care and precision needed by the laboratory side of the alliance can't be overstated.
Hello, Dental Laboratory, Brian here. Sorry to trouble you. Did you receive...
And if either the technician or the clinician are in any doubt about the job, they should talk to each other for as long and as often as necessary.
On the clasp, on the upper right 6.
Of course I can, yes.
Let's assume all's gone well with the clinical and laboratory sides of the alliance, and the completed denture is now ready for insertion. And so, hopefully, is the patient.
Now I've got it all ready for you. Just like to open for me. I think you'll find it'll feel a little bit...
When fitting the partial denture, it is of course important to ensure that it can be inserted without difficulty and without causing any discomfort. If the master cast has been prepared correctly in the laboratory, and the unwanted undercuts eliminated, the procedure should take no more than a minute or two.
Chew up and down.
Once the denture has been seated, the usual checks are carried out to ensure that the various components fit accurately on the teeth and mucosa.
Lovely, and back to the side.
Finally, it's vital to check that the denture doesn't interfere with the patient's normal occlusal contacts and that the appearance is as planned.
And how does that feel?
Seems okay. Instructing, advising and supporting the new denture wearer is also a part of the team effort.
Now, having shown you how to put your denture in and out, it's now your turn. So if you'd like to take it...
At this point, the alliance between clinician and patient can be further strengthened as a result of good advice being given on how to insert and remove the denture, on the significance of the path of insertion, and by pointing out those components which are liable to be distorted unless care is taken.
Together, you can feel that it's correct.
A confident and well-informed patient is more likely to be a cooperative patient.
How does that feel?
Seems comfortable, yes.
And the dentist, or possibly the hygienist, has a crucial role to play in the control of plaque and maintenance of the denture.
Now, I'm just going to put some solution on this denture now.
One good way of showing patients how to take care of their mouth and dentures is by encouraging them to use disclosing solutions or tablets to check the efficiency of cleaning.
Okay, and this goes all around the denture.
And as well as the hygienist, both the DSA and the receptionist can play a supporting role, particularly on the phone by reinforcing the good advice of the dentist. But no matter how good the advice or support, the patient must put it into practice. So make sure that the patient returns for regular reviews appropriate to his or her individual needs. And one final word on instructions. Make sure they're given verbally and in printed form.
Fine. Thank you very much.
As we said at the outset of this program, good partial denture design is a team effort. Its success dependent upon this triple alliance.
This program has only been able to touch on the detail of good partial denture design. The enclosed booklet takes the subject further and gives references to further reading.